Hi everyone, welcome to European Respiratory Society webinar dedicated to evidence-based e-health for COPD. So my name is Vitaly Pobrezhets. I am a clinical researcher and physician from National Pirogov Memorial Medical University, and today I'm going to be a chair and moderator of this webinar. First of all, I would like to highlight a few aims of our webinar. So we are going to discuss the potential of implementation of e-health technologies for routine care of patients with COPD. We'll talk about novel methods of telemonitoring, tele-rehabilitation, different wearable technologies, and eHealth interventions for different groups of COPD patients. And after the end of this webinar, I hope everyone will understand the main positive sides and challenges for adoption of implementation of e-health solutions in your own clinical practice. And our great speakers, I hope they will help you to understand all these questions. Our webinar will contain two presentations, each of the 20 minutes. And after this presentation, there will be a 16-minute Q&A section where everybody may ask questions to our speakers. Also, I encourage you to ask questions not only during this Q&A session, but through the chat. You may pass these questions during presentations, but the answers will be only in this separate session. And first of all, I would like to present our speakers. It will be Dr. Michele Vitaka. So Michele is representative of the respiratory and rehabilitative unit of the Scientific Institute Clinic of Maugeri, Lumezzane, Italy. Michele was a chair of ERS task force dedicated to telemonitoring of ventilatory-dependent patients. So he has a huge experience in tele-rehabilitation and telemonitoring, and I'm eager to hear his presentation. So Michele, if you can hear me, maybe you say a few words to our audience.
Sorry?
Okay, I just would like to pass you ability to say hi to our audience.
But I am the second speaker, not the first.
Yeah. So sorry.
Sorry.
Yes, just the ability so for participants to see you. So okay, we'll start with Professor Niels Chavanez. So Niels is a professor of primary care medicine and chair of eHealth applications in population health management. Head of preventive and lifestyle research council of Leiden University Medical Center. And also Niels is a founder of National eHealth Living Lab in Netherlands. So with a huge experience in self-management of by eHealth for patients with COPD and eHealth solutions for predicting and preventing acute exacerbations of COPD. So Niels, please, the floor is yours.
Thank you so much, Vitaly. Very happy to speak here. And I see that there's a lot of different nationalities in the audience. So I'm hoping for many questions to get a lively discussion on your experiences and your insights on eHealth. Well, the National eHealth Living Lab in the Netherlands is actually very international. So many studies are being performed, not just in the tiny country of the Netherlands, but all over the world. And it's growing rapidly. So right now there's 54 people working there, PhD researchers, postdoc researchers, assistant professors, and I'm very happy to lead the pack. Next, please. So we work together with many companies and institutions all over the world, but our main aim is to publish any scientific information. So all studies that we perform are out there in the open science field, so everybody can take care of and know about all our results. And I can tell you that still it's a very young field. Most studies are not yet ready for implementation. About 10 to 15% of our studies show positive results. So it's very important to show which are the ones that actually work and why. So I hope to give you a little overview about COPD applications and which one are useful. And I'm hoping for your input to learn more about your setting. Next, please. So what is eHealth? It's a black box, of course. It's using internet to promote healthcare. So that's very broad. It's from wearables to websites, and it's really picking up, well, as a side effect of the COVID pandemic. For instance, in the Netherlands, 75% of healthcare was suddenly turned into digital during the pandemic last year. And I'm expecting that it will stay at high levels, not that high, but probably in the order of 20 to 30% of healthcare will be delivered in a digital way. So that's a big difference with before the pandemic. Next, please. So I'll just give you a short overview of some eHealth applications to give you a flavor of what's possible and also what seems to work and what's actually still needing some more work before it's ready for implementation. Next, please. So a very important principle in eHealth applications development is that we try to use participatory design. So that means we have multidisciplinary input. We have patients, researchers, professionals, of course, also technical people like developers or designers. And very importantly, let's not forget the people with low health literacy, because often we forget about the people who have very low reading abilities, and it's important to involve them at an early stage. So that we don't lose out on that important category, because most of our difficult patients are actually from those low literacy realms. Next, please. For instance, what we also do in Europe is to build a quality framework for health apps, because that was lacking. And when we were working on this with the European Commission, we found out it's actually lacking all over the world, also in Asia and America. So it soon became a next ISO standard. So that means a global standard for the quality of health apps. And we finished the work, and on the right-hand side, you can see the prototype, which is very similar to something we already know, the energy sticker that we use when we buy washing machines or any other apparatuses. But now it will be suitable for health apps. And then you can see at one site which app is most usable for the aim that you're looking for. And our hope is that as soon as the Commission has approved of it, and we expect this in June, so coming month, this format, similar to an energy sticker, will be used by app stores. Because right now we are looking at 325,000 health apps available through the various app stores, which is of course way too much to make a decision. And through this very simple label, we hope to make a difference by showing which apps are really worthwhile and which not. Next, please. Also partners internationally, this one is Orca, which is the largest app scraper we have in the world. They check all health apps, all those hundreds of thousands of apps every month. And what they saw during the pandemic, there was a steep increase in the use of digital tools. So this is similar all over the world, I guess. Next, please. For instance, our own app, the COVID Radar app, which was brought very early to the pandemic already in April last year. And very soon we had 250,000 users. And now we're already looking at more than 6 million questionnaires delivered through this app back to us. So we can see what symptoms, but also risk behavior is actually leading to more infections. So this is a very lean way of surveillance of COVID through smartphones without compromising privacy, because the app makes use of your postcode region and not your individual address. So people cannot be traced individually, but in the group of people where they live in. And this is probably part of the success of this app. For instance, in the Netherlands, very soon we could see that cough, dyspnea, and the loss of taste and smell were most common symptoms. Of course, this last one was a new finding last year. We also found out that The number of hours spent outside decreased when people had more than 2 symptoms. So not with 1 symptom, but with 2, they started to become cumbersome. And also we found out very soon, before last summer, that parents of young kids do not express more symptoms. So it was actually safe with young kids to participate again. Next, please. Next slide, please. Thank you. We also worked hard on various guidelines and means for healthcare providers, but also the Ministry of Health. So in the center of this picture, there's the Minister of Health of the Netherlands receiving our guidelines for long COVID patients, because we soon found out this was a big problem, people with persistent symptoms after COVID, and of course also the risks for COPD patients as part of respiratory risk patients with COVID pandemic. So we tried to help out in a very practical way with all the information that we gathered. Next, please. Also, we did a scoping exercise already the year before about eHealth tools for COPD in the Netherlands. And we used a systematic way, so that's a scoping review, to see what applications were useful. And out of 47 applications available in the Netherlands for COPD management, we found out that only 5 of those were usable. So again, that's in the same league as only 10 to 15% useful electronic devices for management of health conditions. So that's why we think good scientific research is really necessary. Next, please. And the best one that we found out was the ABC tool for the burden of COPD, which was already developed a couple of years before, making use of a very simple visual aid. And this is the balloon chart. You can find it in several publications about this ABC tool, which is understandable for people with low health literacy as well. It's a principle of the balloon should go up, of course, and it should change color from red to green. And on the horizontal axis, you can see all the variables relevant for COPD management, not just medication, but also all the other variables for COPD. And this is something that people can understand. Next, please. So we published this in BMJ, showing in a cluster RCT that this tool could improve quality of life in COPD, which was really a surprise for us, but also through better experienced quality of care. So the nurses could communicate much better with the patients about their condition, not just endlessly looking at spirometry results, but people, for instance, moving about more every day instead of sitting on the couch and smoking on. And people were able to improve their self-management skills. And that was probably a very important finding. And now this same tool is being developed for diabetes and asthma and cardiovascular patients as well, to get a real eHealth approach for chronic conditions. Of course, the big question is, would the healthcare usage be improved as well through these tools? So that was an open question yet. Next, please. So what we looked at in another real-world study was if there is a difference between COPD patients and heart failure patients in terms of the effects of eHealth and remote monitoring. Because we know from heart failure that it's a very heavy burden, and people really can have big benefits from a monitoring program. And we tried this out in practice in a hospital in the east of the Netherlands. Next, please. Why is this relevant? Because we don't know these comparisons in eHealth yet, and we thought it would be worthwhile to see where the greatest benefits were to reap. So in heart failure, there's of course variables that can change overnight, like weight because of decompensation, cardio, and this can be monitored in a very direct way. With COPD, it's a bit more difficult. We of course have some tools to check for symptoms, but there's not such a thing like sudden change of weight. Of course, things like oxygen saturation would be a very useful one, but at the time of the study, that was not implemented yet. So we saw some differential effects of this study, where hospital outsourced a lot of their care to home care, monitoring in a digital way. Next, please. So there was a help desk available, people could get in touch with, but there was also some red flags in place. For instance, when the clinical condition changed, there could be interventions, and we compared the heart failure patients with the COPD patients. Next, please. So the results of this program with heart failure were quite staggering. You can see in the various graphs that there was a big difference between the remote monitoring and the usual care in a very positive sense. These were all significant differences between usual condition and control and interventions. And the most staggering one was the lowest graph that showed 89% cost reduction, because heart failure is, of course, especially in the serious stages, something that causes a lot of hospital admissions. And this was greatly reduced because patients could be detected much earlier before they had to be admitted again to hospital. So this was a big success. Next, please. In COPD, it was a bit more differentiated. We saw some good results on cost. That's again the lower graph, 54% cost reduction, which was significant. But in terms of clinical differences and hospital days, the difference was not significant. So still there had to be some more tweaking of the system before we could say this really looks promising. And that's probably because COPD is a bit slower in progress than heart failure. And this means that we needed a better indicator. Next, please. So we also looked at a different form of this monitoring for COPD, involving much more patient involvement and even a buddy. Next, please. So it uses a questionnaire to monitor symptoms. Next. But also had a smartwatch with built-in step counter, because that's, of course, a very interesting one with COPD. When people have everyday steps counted in a valid way, and suddenly they stop taking those amounts of steps, that can be an early sign of exacerbation. So steps is probably a very good indicator of changing clinical condition in COPD. Next, please. And we also had a good algorithm with red flags and orange flags when people felt worse or when their steps went down, and also when the buddy, which was a person, a trusted person, like a family member or a neighbor, who was in contact with the patient to help make those decisions. Because when people get sick, they are less able to make decisions like calling the ambulance. So this is interesting that we had blended care, not just technical solutions, but also, let's say, social solutions in place. Next, please. So the results were quite interesting. Patients and their buddies received feedback when the symptoms worsened or the number of steps declined. And after initiation of this program called EMMA COPD, and it was published last week, both the number of hospitalization days and number of exacerbations decreased quite at a staggering number. Really several-fold decrease of exacerbations and hospital days. And we tried to adjust for confounders, but this did not affect the results. So it was only a small study yet, but very promising. Next, please. Also, we looked at how people could be trained to reduce their sick days and start treatment earlier. And we called this Redux. Very interesting as well, because suddenly the patient could be an actor as well. Next, please. And to conclude my presentation, we think that wearables using these principles that I just show you are very promising. Next, please. Using video conferencing is, of course, very low threshold now. Many people are able to use this. Next. We also did this for COVID patients, showing and published last month in ERJ that we could reduce the short stay admission days in suspected COVID patients by threefold, so from 27% to 9%. So this was really important in terms of capacity of hospital. Next, please. And this will probably be very normal in the near future, that people use wearables in chronic conditions to be monitored at home without being admitted to hospital right away. Next, please. And in Leiden, we have integrated this whole system in a secure way in the patient care app called the LUMC Care app. And this is already working for the majority of patients at our university hospital. Next, please. And to come to conclusion, we think that safety of data is of course important, but it's more like a normal way of dealing with patient data now. Many patients are actually afraid of having less contact between doctor and patient. This is not necessary if you use the principle of blended care. It should be reimbursed, and thanks to COVID, this suddenly became reality in our country at least. But I think for healthcare insurers, digital health now is a very logical solution. And I think we still need scientific research to provide the evidence basis for eHealth. Thank you very much.
Thank you very much for your great presentation, and you really helped us to not get baffled with all this huge amount of eHealth technologies and apps for patients with COPD, and all we face with this. And also mentioned comorbid patients, especially patients with heart failure, which is also very common for patients with COPD. Thank you, and I hope we'll have a fruitful discussion during the Q&A session. And now I would like to invite our next speaker, Michele Vitaka, who will present you his presentation about tele-rehabilitation and tele-palliative home care for severe COPD patients. So, Michele, please, the floor is yours.
Thank you very much for your invitation by European Respiratory Society. Thank you to Vitaly and all the participants. So I have no conflict of interest. So my experience since 15 years about this topic is coming from the scenario, coming from our daily experience. So we know that aging is increasing, chronic disease is increasing, patients, in particular COPD, have low physical activity. The cost dedicated to chronicity is increasing. We know that our patients have very poor adherence to drugs, oxygen, and so on. They are aged and they are at risk of falls. We know that sometimes we have very difficult to discharge patients from hospital when patients present home mechanical ventilation, in particular when they are tracheotomized, and in particular when they are particularly frail. So we know also that it is very important to obtain an early diagnosis and treatment of relapses, in particular for COPD. And last but not least, the COVID pandemic has pushed dramatically the use of eHealth. So the first question to the audience, and I invite to vote, is what is your opinion about the main component of digital health systems? Improve access, to reduce costs, to improve care coordination, or to improve quality care? Okay. Okay, the majority quality of care. So next, in my experience, all the answer is correct. But I agree that in the majority of the cases, we need to improve quality of care, and in particular to improve education, maintenance program, and to improve adherence. But eHealth may also dramatically improve access to, for example, patients in remote conditions, is able to coordinate with the help of a case manager that is usually a nurse, but maybe also a physiotherapist or a doctor, and in some cases may also decrease the costs. Technology is really a lot of technology we have. So we can perform at a distance spirometry. We can have a clear breathing pattern trend coming from a spirometry or coming from a mechanical ventilators. We can see images. We can see every breath of our patients breathing under mechanical ventilation. We can have a good saturimetric trend. We can have a video conference. We can perform a sleep study at a distance, and we can also predict some relapses, incoming relapses, when patients is using his ventilator. But in the majority of the cases, technology to be used could be safe, feasible, effective, sustainable, and flexible to different patient conditions. In our experience in my research hospital since 15, 20 years, we have followed a lot of different diseases. The majority was chronic heart failure, but also COPD, and in particular very severe patients with COPD with chronic respiratory failure, but also neuromuscular disease, in particular degenerative diseases like amyotrophic lateral sclerosis, but also post-cardiac surgical patients, post-ictus, hypertension, and aged people with risks of falls. So the second question to the audience: what is, in your opinion, the ideal COPD candidate for eHealth? Younger than 60 years, aged under long-term oxygen therapy and home mechanical ventilation with comorbidity, and health consumer, not adherent to drugs, living in a rural area with anxiety and depression. Okay. Okay, the majority of the audience answer living in a rural area, and the other is okay, good. So also in these cases, coming from literature and coming from my personal experience, the better candidate seems to be not a very aged COPD, a COPD with a GOLD 3 and 4, frail, we under long-term oxygen therapy and home mechanical ventilation, with a lot of comorbidities, in particular cardiac comorbidity, when he is a consumer of health. So he presents a lot of relapses, admission in hospital, with a lot of urgent GP visits, presenting bad lifestyles when he is not adherent to drugs, living in a rural area, but with a bit of anxiety, with mild depression, when he is presenting symptoms like dyspnea, when he uses prednisone in oral intake. But the patient had to be also with adequate awareness of the disease, a bit compliant, with the presence of a caregiver, sufficient autonomous, and sometimes it's useful eHealth when there is a new therapeutic step. For example, when we change drugs, when we apply oxygen, when we apply home mechanical ventilations. This is our home and our hospital. You can see really my hospital is in the north of Italy, and so this is my hospital, and we have a case manager, a nurse, or a physiotherapist, and the doctor is a second opinion. A doctor may be a pulmonologist, a cardiologist, a neurologist, and so we have the GP at home and the patient, and he receive some devices to monitor some clinical signs and according to the disease. And we have also a call center, a private call center, who receive all this information, and the call center sends to the hospital images and phone calls 24 hours a day. When a case manager and a second opinion is able to answer directly to the patient or with a second opinion to the GP. Regarding tele-rehabilitation, a lot of different devices has been used. So, for example, only telephone, video conferencing, some more sophisticated internet platforms with remote monitoring, and in some cases, a smartphone application with a prescription of oximeter, steps counter, a bicycle, remote control, and interactive TV software. In some cases, very small cases, there is also the possibility to monitor a real-time domiciliary cycle training. And in another cases, patients received at home a treadmill for his exercises with weekly video conferences sessions. In general, tele-rehabilitation with or without video conference has demonstrated that it is feasible, safe, and cost-effectiveness, useful to improve effort tolerance, endurance, training, physical activity, dyspnea, self-efficacy, mood, and quality of life. No definitive data has been demonstrated to demonstrate that this modality of tele-rehabilitation is able to substitute, for example, outpatient rehabilitation. So there are some studies of non-inferiority or in some cases of equivalence to supervised center-based rehabilitation, but no definitive data are available. It is useful in zones with poor rehabilitation access and in patients with COPD plus chronic heart failures. This is our modality to follow very severe patients. This is a paper published a lot of years ago. All COPD patients were very sick. We have also other kind of patients with neuromuscular disease and amyotrophic lateral sclerosis, but we have pushed our COPD patients all with invasive mechanical ventilation or with a non-invasive mechanical ventilation in a teleassistance arm versus a control arm in a randomized control study. And we use a third generation system of eHealth that is a constant analytic and decision-making support with a monitoring 24 hours a day with the availability of a nurse who was able to answer as a first step to patients and to call in second opinion the pulmonologist or the cardiologist or the neurologist. Under this system, we were able, in some cases, to perform a video conference with the caregivers to improve their level of education. You can see, for example, during suction of a tracheotomized patients. But the video conference is also useful to have a clinical examination, to check the material of the mechanical ventilators. Is possible also to see the tracing of the ventilator, why a ventilator is alarming, and is also possible to see the caregiver how to put the masks on the face of the patient. According to this study, we have demonstrated that teleassistance in chronic respiratory failure was useful when compared to control arms to reduce exacerbation, GP urgent calls, hospitalization, and emergency room admissions, but in particular in the COPD subgroup, and also subtracting the cost of the teleassistance, the average cost per patient was 30% less when compared to the control groups. But another question was, but what really the teleassistance is able to add when a COPD patient, in particular very severe, under long-term oxygen therapy and under non-invasive mechanical ventilation, is discharged to home? Because we know that oxygen therapy and non-invasive mechanical ventilation per se is prescribed to reduce exacerbation and to reduce hospitalizations. In this retrospective study, we have compared 4 subgroups of patients of COPD, subgroup patients, in which we have prescribed only long-term oxygen therapy and non-NIV, oxygen therapy and teleassistance, and both oxygen therapy, NIV, and teleassistance. So the conclusion of this retrospective study was that adding teleassistance, we were able to reduce exacerbations, but not hospitalizations, probably because it's related to a lot of different habits when we decide to hospitalize a patient. But literature about the usefulness of eHealth and telemonitoring and telemedicine is really debated with contradictory studies. For example, all the studies coming from UK are negative. Some study coming from different European countries are positive and negative according to different outcomes. Some studies coming from Portugal and other study coming from Italy and Spain are positive. So this is really interesting because in my opinion, and this is also my one point of my conclusion, it is very crucial what is the control when we compare telemonitoring and controls, because in very sophisticated or more aggressive home care system, probably when we had telemonitoring, we can obtain less strong outcomes, less strong results. Another very important rationale for telemonitoring, really recent, after in particular the COVID epidemic, is to monitor, to adapt and to monitor adherence, leaks, volumes, and apneas of our patients submitted to home mechanical ventilation. And so you can see day by day the adherence of our patients, and it's possible to see all the tracing, and we can also to change the setting of our mechanical ventilators. And I think that in the future, this may be very, very important in our routine practice. Another interesting point is the patient point of view. In this survey coming from the European Lung Foundation, one of the questions we propose to our home mechanical ventilators patients is, would you happy for your health professional to monitor your ventilator remotely? So the answer was yes in the half of the cases, but in half of the cases they answer maybe or no. So, and this is very interesting. And the reason of answering no is because the telemonitoring feels like a big brother. There is poor privacy about my personal information, data, and so on. Another topic is very sick patients coming from intensive care unit. And in this randomized control study, we discharge patients at home, 48 patients coming from high intensive care unit sequelae. And in the treatment group, we performed 2 sessions a day of breathing technique. We prescribe physical activity training, telenursing, telecoaching with the help of their caregivers, while the controls underwent standard care. So in Italy is nothing. Results, so these strong home care of direct home assess plus telenursing and telecoaching was able to improve respiratory muscles, to improve the speed to remove tracheostomy, to improve pulmonary function and health status. Another study was proposed in this randomized control study in my hospital for COPD and heart failure. And also in these cases, we have randomized more than 100 patients, and we applied for 4 months in home program with remote monitoring of cardiorespiratory parameters, with weekly phone calls by the nurse and exercise program monitored weekly by a physiotherapist. So also in these cases, the effort tolerance was improved only in the intervention group, and this data was maintained also after the end of this program, and also the time to hospitalization or death was in favor of this program. The last topic is the telepalliation, a very particular topic. And we have performed this small experience with a nurse-centered telemedicine program for patients with a very severe chronic respiratory failure. In the majority of the cases, they were COPD, in which we offer to the GPs and to the caregivers and to the patients a continuous monitoring in the last phase of their life. And the phone calls and the topic used by the telemonitoring was to prescribe morphine, sedative prescription, to speak about the cardiopulmonary resuscitation, or to obtain an hospice access, or to obtain a doctor visit, or to improve the dysphagia or the oxygen prescription. Sorry. So we have at this moment both opportunities and challenges when we prescribe telemedicine in chronic respiratory failure. So the opportunities to reduce travel, to improve monitoring, reduce the caregiver burden, reduce attendance at the GP, reduce hospitalization, and so on. But we have a lot of challenges in terms of acceptance by the healthcare professional, about the familiarity with technology, about the cost, about the data security, about the reimbursement, and so on. So to conclude, we know that in every cases in medicine, when we have some new drugs, when we have a new condition, there is a very increase in trigger, with a very inflated expectation, with a push by industry, by telemedicine users, by also politicians, and by patient end users. And after this peak of expectation, we have more skepticism, a lot of data with a negative results, because we have a low generalization and so on. And we usually have a time of disillusion, but we need to obtain a plateau status in which we need to focus what is really telemedicine. Telemedicine is a means to an end and not an end in itself. And to conclude, both telecare, telerehabilitation, telenurse may be useful in COPD and in very severe COPD patients, but clinical studies are heterogeneous, small, and conclusions remains equivocal. We know that available technologies are really promising, and in healthy system with well-organized home care, probably telemedicine may offers less advantages. Actual challenges is related to the target population, the cost effectiveness, the legal consideration, security, and clinician responsibility. We need well-designed multi-center studies with a non-intrusive package to improve the adherence of our patients. And finally, in my experience, only a big package of health answers, and not only telemedicine, may really answer to the necessity of our patients. Thank you very much for your attention.
Dear Michele, thank you for your great presentation. So you really make much more clearer how to choose a correct patient for using telemedicine. So now I understand what are the main approaches and how to organize an effective teleassistance for COPD patients. And I'm very happy with that fact that both of our speakers, they appreciate the importance of involving end users to create the really effective eHealth system for patients with COPD, because without this participatory approach, it's impossible to do this. So, and now let's start our Q&A session. I would like to start from the first question, which was addressed to the Niels. So Giovanni Vighetti would like to know opinion about what the most important unmet health needs of usual care model can eHealth fulfill. So Niels, what do you think about this potential?
Yeah, so Giovanni, thank you. Great question. What we don't realize as clinicians is that there's a lot of untapped potential in the data that people can provide to us through their home situation using wearables. For instance, the walking distances, as I showed you, we almost never know how many steps people are actually taking on a daily basis. We also don't know what their actual symptom patterns are, because we only can ask maybe once a year. So by using, for instance, the CCQ, which is a very simple measure, the CAT could be equivalent, we know much more about the daily situation of patients, how active they are. And another one that I already mentioned is oxygen saturation. Of course, it's not a good measure to have a real insight into blood gases. But if you know every day saturations of peripheral patients, you can see a clear drop of over 3%, which could be the first sign of an exacerbation coming up. And the same holds true, of course, for COVID, as we now know. So these very simple measures, measured in a very routine way, every day, preferably, can show patterns that we never knew about because we never saw patients enough. And I'm confident that by using these large amounts of data of large patient groups, we can get to new algorithms that can detect deterioration much earlier than we can do now.
Yeah, totally agree with you. And with this idea that really is important to measure the dynamics of these parameters with the time, it really could help to detect patients who are in risk, even in the early stages, without drop of these parameters. Thank you, Niles. And next question I would like to address to Michele. So above Johannes, he would like to know what are your thoughts in terms of increasing acceptance of telehealth technologies to healthcare professionals and patients and caregivers? How to increase this acceptance and use of the technologies through these stakeholders?
Yeah, this is a very crucial point. Usually COPD patients, at least in Italy, they are, but I think also in the other countries, they are quite aged. Uh, and so they are not so confident with technology. Up to date, their technology is the TV. I think that if we would able to put inside the TV a lot of exercises and education or other messages, probably maybe a good idea. But now the people is changing, and but also the health professionals had to improve their knowledge, and so we had to wait. I think I believe 1 year, 2 years, but I think that all the technology will be very easy. But the point very important is the flexibility of technology, because we only when we apply this flexibility according to the age of the patient, the condition, what is the real aim? Because I had technology, because we cannot abolish the face-to-face visit or the admission in our offices. So only when we apply good technology to help also our daily practice. For example, to avoid a long office queue, or to avoid useless access to hospital. So we have a lot of technology, and so we need to use each different technology according to each different situation. Exactly what happens in our hospital. We have ICU, we have respiratory ward, we have emergency room. So different opportunities for different condition of patients.
Yes, thank you. So I totally agree with you that elderly patients with COPD they have really low literacy in digital technologies, and it's a really problem when dealing with such patients. And yeah, I agree with you that nevertheless, is a growing literacy among this group of patients is still a problem. And so the same participant addressed a question is quite interesting. So it's about, should we make eHealth wearable technologies as a mandatory for COPD patients with chronic heart failure? So it's comes with this question about contact tracing apps for patients with coronavirus. So should it be mandatory, or patient who must have ability to choose where it's used or not? So Niels, first of all, I'd like to hear your opinion about this.
Well, I don't know if the evidence is firm enough yet to make it mandatory. And also, as I said before, I think a blended care approach is more promising. So we should equip our existing healthcare approaches with technical ability to know better what the patterns are that our patients are showing every day, so we can make better informed decisions together with the patient. And by making it mandatory, it becomes almost negative, I think. We should highlight what's in it for them, for the patient. What can they gain by using these technologies? And the same holds true for us as clinicians. What is in it for us? For instance, as Michele said, lower waiting times, or maybe less stressful outpatient clinics with fewer moments that we lose, and better informed decision making, especially making use of the abilities of patients. So we should always highlight the positive side, and by making it mandatory, it can be quite the opposite.
Yes, thank you. So I understood the patient will probably think that it's like a stigma. So you have disease, and it will be just a something that will afraid them. So Michele, do you agree with this opinion?
Yeah, I agree completely. Thank you.
Great. So Jordan Bukers would like to know, so besides steps, which are the measurements from wearables do you think are the most useful? So apparently this question is addressed to Niels. What do you think about this? So what we could measure through the wearables?
Yeah, so the most promising ones I already mentioned. A simple questionnaire that can be filled out every day, like the CCQ or the CAT, which gives a good impression. And also the oxygen saturation, especially when you measure it, let's say every day, not continuously, that would be too much. But if you have one measurement every day, you can see patterns during the week. And then suddenly you maybe see that the rates are dropping 3 days in a row. And that could be the start of an extubation. So those are promising ones.
And so I have following questions is, so you mentioned about COPD patients who use both wearable device and smartphone application for assessing symptoms. So isn't too much for the patients? So or patient like to use several devices? Because for instance, I have a ZOF patient who don't want to use just an application. So and not talking about application in both wearable device. So is it a restriction or it's not a restriction for using it?
I think it is a restriction. So therefore, it should be very simple and cost hardly any effort. It cannot be long questionnaires, for instance, because people will stop doing it. And the other detail that I wanted to highlight, Michele probably sees much more severe patients than I do, especially when people are very severe and acquainted with long admissions and in the palliative phase. They are much more motivated to take care of themselves because they know what's happening. When people are more in the earlier stages of disease, like I see them a lot in primary care, they are much less motivated. So the more symptoms people have, the better they will act.
Vitaly?
Yeah, Michele.
Can I add about the technology and the wearable and so? So
Sure.
we need to believe that there are obviously a lot of different countries with not so high level of incoming, and so we need also to propose some very simple instruments. And for example, about technology, is the phone is a very simple, very simple technology with a case manager, and this is the basic technology. And when a patient and the caregiver have the possibility to contact all the day or at least 8 hours per day, a direct call, we have improved dramatically their monitoring. And another point, very interesting, that Niels before have said is about the number of steps. So their activity, and when the activity is changing, so they became bedridden or they stay in their home, this is incoming the relapses. And so phone and this very practical education point about activity and respiratory rate and saturation, obviously, we can perform a lot of very good monitoring in the majority of the cases.
Yes, thank you. So indeed, we should take into account the resources available in each situation. And so I remember about different digital technologies for improving adherence to TB treatment in rural areas of the Central Africa with just short messages. And that will be enough to improve it gradually. So it will be great. And Michele, I would like to ask a question from Ipek Osman. So here's a question about is there a legal regulation of telemonitoring in your country? So how we can ensure our patients about the privacy and data protection of, because this monitoring is about health data, which are really important for the patients.
Yeah, this is a very important point. we have some standards, but not in all different regions of my country, but also in Europe. I know that there is a very different legal standards, but in my experience, we recorded every phone with our patients, and every action is recorded and is able to be maintained inside our platform. And so the privacy and the legal effect is maintained. But obviously, more complicated is, for example, to monitor and to change, for example, setting of a ventilator at a distance. Actually, in my country, it's possible to change the CPAP for obstructive sleep apnea patients, but actually is not so clear to change, for example, inspiratory and expiratory pressure or patients with tracheostomy. And actually, we cannot perform this. I think that at European level and also from our society, we need to push for obtain more standards about this.
Thank you
I
very
agree
much.
completely.
So we have a lot of other questions, but unfortunately, we have time limits for our webinar. So I would like to thank our speakers for this huge materials they shared with us. It was really great, and it was exciting to understand now better all these health technologies. And I'd like to use the opportunity to encourage everyone, those who do this, to send your abstracts and clinical cases to European Respiratory Society Congress 2021. So the submission deadline now is postnoted to 14 June, so you still have time to do this. And as the chair of eHealth and Health Group, I am welcome to contact with you about your ideas about our future webinars. So I hope that it's just a beginning. And with Mikkel and with Niels, we will speak again here or during the conference and share with you all our experience. Thank you very much. Have a nice day. Goodbye, everybody.